just make the best of the presentation of today. And I know we are getting fatigued a little bit. We've spent here about 40 minutes, and we need to get into us doing what brought us here. Today I'm taking you through the uterine artery, obstetric Doppler of the uterine artery. Why do we do the obstetric Doppler of the uterine artery? We do it mainly in first trimester to screen for the early onset of complications such as preeclampsia, and in second trimester in order to rule out late preeclampsia or evaluation of the pregnancies that we have already seen in first trimester that have been complicated by fetal growth restrictions. The key indications that will make the clinicians think of asking for Doppler involving the uterine artery will include history of preeclampsia in order to rule out patient preeclampsia who has had history of preeclampsia, who is having unexplained high levels of alpha fetoprotein and HCG levels, or history of having a child with intrauterine growth retardation. What is the uterine artery? As he said, as Mr. Lukenga already told us, the uterine artery is a major blood supply to the uterus. And it is a branch of the internal iliac artery. We could see clearly that this is the abdominal aorta. It branches, this is the common iliac artery, the internal iliac and the external iliac. This is the uterine artery. It moves parallel with the adjacent vein, and it's a branch of the internal iliac artery, and it enters the uterus at the junction of the corpus and the cervix. Just another demonstration such that we are able to grasp it. The common iliac artery, the external, and then the internal, and here is the uterine artery that supplies the uterus. Where it supplies the uterus, the key thing that we shall be talking about is as it enters the myometrium to form the arcuate, and at the terminal end we have the spiral arteries, and the spiral arteries are coiled and having a very high resistance waveform. What is Doppler ultrasound scan of the uterine artery? This is a specific ultrasound technique that measures the flow of blood in the uterine artery. That's it. In the non-pregnant state, the waveform, as we say, is one in systole and in diastole. So in systole, it has a sharp rise and a sharp fall. In diastole, there is an early diastolic notching, as we can see clearly with this, and a low end diastolic flow. Sharp rise and sharp fall in systole. In diastole, diastolic notch and a low diastolic flow. He has been telling us about the vesicular bed that is being provided, that the blood vessel is supplied. And what is key here is for successful placentation to happen, there should be remodeling of the uterine artery for successful placentation to happen. What causes during this? During normal pregnancies, cytotrophoblastic cells will migrate outside of the evolving placenta, assuming the placenta is being made in here. And then where do they go? They migrate to the decidua around the uterus and then into the myometrium. So this cytoplastic invasion results into the remodeling of the spiral arteries. What happens during the process of the remodeling of the spiral arteries? I'm explaining this because they are the reasons why we shall be looking, why the waveforms will be looking the way how they will be looking. So these spiral arteries will be remodeled. They will increase, vasodilate, and then become low resistant. Hence, here in the first trimester, in the normal, we have a high resistance waveform. But you realize as placentation is happening, the low resistance waveform will have to be able to come into place. So the spiral arteries become dilated and that area becomes a low resistance bed requiring a lot of blood flow into it, And this changes the shape of the uterine artery Doppler waveform. That's the difference from the non-pregnant to the one of a pregnant. So this picture has already been explained as we talk about the site of trophoblastic invasion. If there is inadequate remodeling of the spiral arteries, like in cases of preeclampsia, this is where these are the key signs or the key things that we should be looking at in order for us to realize that there is a problem or there might be a problem with this pregnancy. First trimester uterine artery Doppler technique. We could either use the transabdominal or the transvaginal approach. What do we do in both approaches? We sample the uterine artery near the internal os or at the crossover of the iliac artery 1 to 2 centimeters. The angle should be less than 60 centimeters, and we should be able to measure the pulsatility index and the resistive index of both. That means the left and the right uterine arteries independently, and we should be able to see clearly that there is no end diastolic notch. For example, this waveform is okay in early first trimester with a diastolic notch. Early in first trimester. In early second trimester, the notch is there, but it is slowly disappearing. And this is the kind of waveform we expect in late second trimester and onwards, giving us a waveform that has a very low resistance waveform, as shown by the in lack of the diastolic notch and the increase in the amount of blood that is being pulled depending on the site that is being supplied. So in transabdominal technique, it's essential for us to be able to empty the bladder. In the mid-sagittal section, we look at the uterus and then we identify where the cervix is. The probe is moved a little bit on the lateral end in order for us to identify the paracervical plexus because there are blood vessels around that area. Color Doppler will give us a better visualization of them. And then when we realize or when we see where the uterine artery is, we measure and record Doppler spectral parameters. It's done both on the right and on the left. Once again, we should be able, the stage at which we do these measurements is very key in us determining whether what we are doing or the kind of waveform that we are getting is the right waveform or not the right waveform. In the second trimester, we have the transvaginal technique still, but here transvaginal, we press the probe, the transvaginal probe in the anterior fornix, and then we move it laterally on the lateral fornix, on the right lateral, in order for us to be able to visualize the right uterine artery, on the left lateral, in order for us to visualize the left uterine artery. When we visualize it, still we put color Doppler and sample and get the Doppler spectra. So the biggest thing is where you put the probe and how you angle to get to the right vessel. So here, sometimes because of the paracervical vesicular plexus, we should take care not to insonate the cervical vaginal artery. We shall look at it and how it branches off from the other. And typically velocities over 50 centimeters are typical for the uterine arteries where we cannot adequately discern. So in the second and third trimester, the technique still, the transducer is placed on the lower outer or the lower quadrant of the abdomen in longitudinal section. We still use color to identify them, but where do we look? Remember, at this time, the abdomen is big or the stomach is big, as the lay people would normally say. And because it has dilated, so we move the probe a little bit more medially and angle inferiorly into the symphysis pubis, but we should be able to put our color Doppler at the point of the iliacs, just as they pass the iliac, as the uterine artery passes the iliac, and 1 to 2 centimeters, just immediately it passes the iliac. That's where we should obtain our Doppler sample from. The transvaginal technique, we still empty the bladder and the patient is in dorsolithotomy position. Probe is placed in the lateral fornix and the uterine artery is identified using color Doppler. at the level of the internal os. And after that, we still follow to see where it is. We put color, and then we optimize, and then we sample and get the Doppler spectrum. So what is key is here, this is the point where the iliac vessels are crossing, and this is the uterine artery. So at this point, before the uterine artery has divided to form the cervical portion and the uterine portion, about 1 to 2 centimeters from these is where we are required to be able to get the point of, we're also supposed to see the point of maximum velocity through looking at aliasing, and that is the proper point for us to be able to sample. What is normal and what is abnormal? Initially, the high resistance waveform with an early diastolic notch, especially in first trimester and early second trimester, before complete presentation happens, is okay. But after 24 weeks, we have seen that physiological trophoblastic invasion has taken place, which leads to a demand of a lot of blood, which reduces the resistance of the area, which causes the early diastolic notch to disappear and increase in the flow, in the amount of blood that is there. So the pulsatility index should be below the 95th percentile for the gestation age. What is abnormal? Persistence of a high resistance or persistence of an early diastolic notch beyond the 24 weeks will suggest inadequate trophoblastic invasion. Okay. This pattern significantly increases if we see the persistence of a high resistance waveform or an early diastolic notch. We think of IUGR, placental abruptio, pre-eclampsia. And if the pulse index is greater than the 95th percentile, or the resistive index is greater than 0.6 of the vessel, still the low resistance waveform is okay. Continuous forward diastolic flow is okay. No diastolic notching is beautiful. Pulse index and resistive index within the expected range for gestation age is okay. What is abnormal is a high resistance waveform, decreased or absent end diastolic flow. Still, just for us to be sure that we are still together. Have I gotten a technical glitch?
Christopher, we can hear you very well.
Okay, my screen is not moving.
Oh.
Okay, technically, what we are talking about is the presence of an early diastolic notch issue in the uterine artery. I really don't know what has happened on my side. Okay, so can you still hear me?
Very well.
Can you see my screen?
Yes, but I'm seeing the very first page or slide.
My screen. I'm not seeing my screen, unfortunately. So the biggest thing that is remaining
May I request Mr. Ndaula to take over your slide so he can help you to scroll.
Okay.
You can go ahead as Mr. Ndaula takes over the slides. Perhaps you could stop sharing, then Mr. Ndaula can take over the screen sharing. But please go. You could go ahead with the presentation.
The biggest thing that is remaining is the values, and the values of the Doppler indices are recent research have shown, especially the pulsatility index of from 14 weeks onwards up to the 40th week, there is a normal value that changes week by week. And we are supposed to be having that reference table if we are doing uterine artery.
Chris, just a minute. I've been told that you can stop sharing, then reshare. It will fix the glitch you are
That
having.
will cost us time. I have only 2 slides to move, so I guess let me
All
just
right.
talk about the last slide, and then we
No
continue.
problem.
So we have pitfalls that happen with the uterine artery, and some of these pitfalls, or could be any other conditions that could give us conditions that can give us a low resistance waveform in the uterine artery. Some of these can coexist with pregnancy, and some cannot coexist with pregnancy. Conditions such as a malignancy of the ovary, or a malignancy of the uterine, or malignancy of the cervix, it can coexist with the pregnancy, and therefore could lead to false negatives that can be read on the Doppler spectrum. Another thing is proadenomyosis or any other uterine conditions that can affect that. I guess let's move on with the next presenter. That was basically what I had. Thank you.
Thank you, Mr. Birengeso Crispus. That's been the presentation about the uterine artery. Yes, a reminder, if you have a question, put it in the chat. The panelists will be able to answer all the questions at the end of the presentation. Our next presentation is going to be about the uterine artery. Yes, a reminder, we first of all looked at fetal circulation, then physics and hemodynamics, and just now Mr. Birenges has been talking to us about the uterine artery. Next, we are going to be looking at the umbilical artery. We have a presentation by Naume Barije.
Thank you, Mr. Mwanja. Thank you for moderating. Good evening, everyone. So my name is Naume Barije. Unfortunately, I'm not able to join you on live, but I did prepare a presentation for you. I hope you enjoy it.
Yes, we've heard from Naomi. She's not live.
Sorry about the noise. Sorry about the noise, but I hope people heard me. I'll be able to come in after the presentation. I was able to prepare a recording for you guys, basic about artery Doppler. Then also, Mr. Mwanja, you'll help me make some corrections about what we had discussed previously if I'm not able to come in, but I'm on chat right now. I'm available. Thank you.
I'm a sonographer.
Okay,
I work with
thank
Women's
you.
Hospital, Bokoto.
So IT will be airing that recording by Naomi about the uterine artery.
Hi, how are you? I hope you're all
Sorry,
doing well.
about the umbilical artery, and later we shall have a presentation about MCA by Migisa Amina.
Hi, how are you? I hope you're all doing well. My name is Naume Barije. I'm a sonographer. I work with Women's Hospital, Bokoto. It's a fertility hospital. It's a fertility center. My day-to-day work, I deal with IVF patients where we perform scans. That are required by the IVF team, and also when these patients become pregnant, the women become pregnant, we follow them up during the entire pregnancy till birth. My task is to talk about umbilical artery Doppler. These slides were prepared by me and my colleague Amina Migisa, who will be coming in on the middle cerebral artery. So let us start by defining umbilical artery Doppler. It's an ultrasound technique. This is in simple terms. It is an ultrasound.
Hello, am I audible?
Mr. Ndaula, you're audible.
Is it playing perfectly?
Yes, it is. Yes, it is. Though the volume seems a little low, if you could raise it a little.
Sound technique that uses Doppler technology to assess flow of blood within
How about there?
The volume is better.
the umbilical arteries. We're assessing the flow of blood, we're assessing the behavior of blood within the umbilical arteries. We know the umbilical cord has a pair of umbilical arteries, which umbilical arteries carry deoxygenated blood from the fetal saturation. They also carry wastes, which include urea, lactic acid, creatinine, bicarbonates from the fetal saturation into the placenta. Just a minute. Into the placenta that are diffused over into the maternal saturation. And then we know the umbilical vein carries oxygenated blood, and it also carries nourishment and antibodies from previous mother's infection that are diffused over to the fetal saturation. These help the fetus in nourishing the fetus and also in the proper growth of the fetus. Umbilical artery Doppler provides crucial insights into placental resistance and overall function of the fetal placental unit. It also reflects the efficiency of nutrients and oxygen exchange. So with these 2 points, you realize we are talking about the placenta, because the role of the placenta is the unit where exchange of nutrients, of oxygen, of toxins happens in the placental unit. So when someone asks you to perform an umbilical artery Doppler, I want you to get this at the back of your mind. Performing an umbilical artery Doppler is an indirect assessment of the functioning of the placenta. So in other words, they're asking you, is the placenta doing its job? And by assessing the functionality of the placenta, it gives you an insight on the fetal well-being. Why do we perform an umbilical artery Doppler? So primarily, we perform umbilical artery Doppler on high-risk pregnancies. If the pregnancy is low risk, there is really no need of performing an umbilical artery Doppler. What do I mean by high-risk pregnancies? These are pregnancies that pose risk of fetal growth restriction and that point towards poor perinatal outcome. Examples of maternal conditions that lie under high-risk pregnancy. This is a mother with diabetes mellitus, a mother with hypertension, a mother with chronic kidney disease, prothrombotic states, name them, okay? And then we also have pregnancy-related conditions. This could be history of having an IUGR fetus in the previous pregnancy, history of having an intrauterine fetal demise in the previous pregnancy. A patient presents with oligohydramnios, a patient presents with polyhydramnios, a patient complains that they're not feeling the fetal movements. All those should indicate our indication letting you know that you need to do an umbilical artery Doppler and find out if the fetal placental unit is functioning well. We also perform umbilical artery
Mr. Ndaula,
in monitoring and timing of delivery.
Mr.
Yes, hello.
Your black screen was hiding the presenter's slides.
Okay.
But I think it's now fixed. Thank you.
Delivery of fetus compromised by fetal growth restriction. So this one I think is self-explanatory. After performing an umbilical artery Doppler, depending on the severity of the findings, sometimes you're required to monitor by ultrasound, and then also as the clinicians, time for delivery for this fetus that has been compromised. And then we also have staging of twin-twin transfusion syndrome. Now, for me who works with IVF, the majority of my patients have multiple pregnancies. So yes, we are most likely going to land on an issue on a case of twin-twin transfusion syndrome, monochorionic pregnancies. However, Not every monochorionic pregnancy, multiple pregnancy, suffers twin-twin transfusion syndrome. But once you see that, then you know you are at risk. So you monitor, and regardless of the gestational age, you monitor from the time that you can, maybe 15 weeks onwards. You keep monitoring the Dopplers, the weights of the fetuses, the amniotic liquor volume, everything basically that is required under monitoring for twin-twin transfusion syndrome. When do we perform umbilical artery Doppler? The books say 24 weeks, but by 20 weeks, we expect to have high resistance in umbilical artery Doppler, high resistance of the placenta in umbilical artery Doppler. It would be also nice to sample at that time if a patient comes in for an anomaly scan. Why not? Okay. So, and chances are that by the time the umbilical artery Doppler gives you abnormal values, you will have impaired uterine placental saturation. So the mother's blood supply from the uterine arteries will be impaired already. So like Mr. Birengeso has talked about that, it starts from the mother's saturation before it comes to the fetus. So it will start with impairment of the uterine saturation, and then we have impaired umbilical artery Doppler, and then we shall have the middle cerebral artery Doppler that is impaired. And whenever TTTS is suspected, please sample umbilical artery Doppler at any time. My next slide here is a diagram of the fetal saturation. As you can see here, the umbilical arteries are a branch of the internal iliacs. And then we have the umbilical vein, which enters the fetal abdomen through the fetal liver, shunts oxygenated blood into the IVC that empties into the right heart chambers. Someone else will cover this bit. Then also here we have an illustration of how the placenta unit looks like. Like I said, when they're asking you to perform an umbilical artery Doppler, they are literally asking you, how is the placenta functioning? That is the question you're going to answer at the end of the day. The placenta's functionality, and also when you answer the placenta functionality, you'll be giving them insight on how this fetus is doing, the fetal well-being. So these are blood vessels from the maternal end, the veins and the arteries. They enter and pour into these spaces here, which are called the intervillar spaces. You read more about the anatomy of the placenta, just giving you a brief snapshot. And then this is the umbilical cord with a vein and the arteries that differentiate into these secondary branchings or network of vessels that enter into these intervillar spaces. But the blood coming from the mother and that of the fetus do not mix at all. They are covered by what we call a placental membrane or a placental barrier. So, but this barrier is a very thin membrane that allows exchange of oxygen, nutrients, antibodies across the membrane into the maternal saturation and vice versa. However, with some kinds of infections, you've heard of hepatitis, herpes, syphilis, with malaria as well, they cause damage to the placental barrier here, causing inflammation of the placenta. You can read up the pathophysiology as to what exactly happens here. But yes, this membrane can be damaged. And when it's damaged, some antigens can cross over and attack the fetal saturation. What are we looking out for when doing an umbilical artery Doppler? First of all, we are monitoring the fetal well-being by detecting changes in blood flow patterns, particularly high resistance or absent in diastolic flow, which can signal placental insufficiency or placental dysfunction, and consequently potential fetal growth restriction. So we are looking out for the functionality of the placenta. If the placenta is not functioning well, that means it hinders the fetal well-being. And you could have consequences such as fetal growth restriction. So we are looking out for any changes in blood flow patterns. We shall be looking at the velocities and the waveforms, but we are particularly interested in the resistive indices, the resistance within the placenta. So if there is high resistance or absent end diastolic flow, when we are sampling our umbilical artery Doppler, it points us towards possible placental dysfunction. So I want us to talk about the umbilical artery Doppler technique. First of all, explain this procedure to your patient and why you want to perform this umbilical artery Doppler. Okay. Then position your patient in supine, not completely supine, we all know that. However, you can do a left lateral tilt as well to avoid compression of the vena cava, especially when your mother is very heavy. Using B mode, identify a free loop of the umbilical cord. Free loop meaning we want this loop to be free of compression, and we also want to avoid the cord insertions at the fetal end and at the placental end. Why do we want to avoid those sites? Because at the entry and exit points at those ends, the resistance is usually high and the velocities can also be exaggerated. So you want to avoid the ends, the cord insertions. So preferably a free floating loop midway the cord insertions. Your area of interest should at least fill 50% of the screen. Okay. Activate. You can also use color Doppler. Here, rather after B mode, use color Doppler to help you identify the artery and the veins, to help you differentiate those. Area of interest, at least 50%, should cover at least 50% of the screen. Activate, press your pulsed wave button. It will bring you the line and the sample gate somewhere there in the middle. Adjust it and align it. Should be perpendicular with the line should be perpendicular with your vessel. So you want to avoid creating false angulations. The angle of insonation in umbilical artery Doppler, because we are interested in resistance, in finding out the resistance within the blood flow in the umbilical arteries and in the placental bed, and we are not interested in the velocities more. Angle of insonation is 0 degrees. That is what is acceptable, 0 degrees. So you do not need to apply any angle when we are going to activate our pulsed wave Doppler. However, some people will say get an angle that is close to 0 degrees. All right. So we want to avoid tilting our line, our pulsed wave line or sample gate, to align ourselves with, just a minute, to align ourselves with, sorry, my phone. You want to avoid tilting that line of the pulsed wave to align yourself with the umbilical cord. So you want to get a free loop that is lying naturally and easily perpendicular to your line of the pulsed wave. You place your sample gate in between that vessel. Sample size gate, about 2 millimeters. Let it fill. Let it be in the middle there. Let it fill your artery of interest. Okay. Activate. When you activate, the acceptable sweep speed should be about 4 to 6 waveforms that are consistent, clear, with accurate tracing. And also you can adjust your scale and make sure that your waveform fills at least 70% of the Y scale, Y axis rather. Then also during this procedure, you want to make sure that you're taking a sample when there are no fetal movements, when the fetus is at rest. Avoid breathing movements, avoid fetal movements. So you take it when the baby is not making movements. Then in cases of multiple pregnancies or a pregnancy that is a term and it's a little bit hard to identify that free loop because from experience, I know it's a bit hard sometimes. So what you do, you come to the umbilical, to the abdominal insertion, the umbilical cord insertion at the abdomen. Just come a bit distal to that area and see if you can identify a loop around there and take a sample from there. Usually when there are changes in resistance within the umbilical artery, it will be first picked in that area there. So just distal to the abdominal insertion, that is in multiple pregnancies and in some pregnancies where it's very hard to get a free loop, sample in that area there. So this is what I was talking about. Get a loop that is aligned very well so that when you put your pulsed wave, it is perpendicular to your area of interest. And then your sample get in there within the artery. Focus zone should be there in the middle so that you're focused on your area of interest. Angle of insonation, 0 degrees, because we're not interested in velocities. However, anyone who has more information on that, we can come in and talk about that as well. So after activating our Doppler, our pulsed wave Doppler, it is going to give us a consistent waveform. Okay, so what does it measure? Then we shall click on calculate, select umbilical artery artery Doppler, and some machines have, if you have a consistent wave, if you activate automatic measurement, it should give you something accurate to if you are also doing it manually. Manually, you pick one cursor, put it at the peak systole, and then the other cursor at the end diastole. It should give you something. Then others, you can put one at one end diastole to another end diastole over consistent waves, and it should measure all that for you and give you accurate measurements as well. So what it measures to give us a peak systolic velocity, this is the highest speed at which blood flows in the umbilical artery during heart contraction. So when the heart contracts, it propels blood at a high speed through these the umbilical arteries. So that is the PSV that you will capture. And then we have end diastolic velocity. This is the lowest speed during the heart's relaxation, or at the end of the heart's relaxation. So the peak systole is the highest peak here that you're seeing. And then as it starts going down, you have what we call early diastole, late diastole, and end diastole. End diastole just before the beginning of the next peak. And then it will also give us the SD ratio. SD ratio, you're basically comparing the peak systolic velocity to the end diastolic velocity. So you get a ratio PSV over ADV. Then it will also give us the pulsatility indices. This quantifies the variance or the inconsistency in blood flow velocities. It will pick on any inconsistency when this blood is flowing through this blood vessel throughout the cardiac cycle. So basically all these measurements here help us assess for vesicular resistance. They're all giving us an insight on the resistance taking place while this blood is flowing through these umbilical arteries. Then also to note, just to take you back to the hemodynamics a little bit, our peak systolic point right here, this is a pressure wave from the fetal heart pump, okay? And then the diastolic component of it is a reflection of the distal bed. And in our case of umbilical artery Doppler, our distal bed is the placenta. That is where blood is flowing to. So blood flowing through the umbilical artery, going to the distal end. And in normal late second, third trimester, normal umbilical artery Doppler, we expect to have reduced resistance. So this is a waveform, a low resistance waveform. Low resistance waveform meaning end diastolic flow volume is increased. Increased because my point of end diastole is very far from the baseline. That is how I know it is increased. And when it is reduced, it will come very close to the baseline. So in this case, I have adequate blood flowing to my distal bed, in this case, the placenta, on end diastole, which is what we want, because we want blood to be flowing freely and adequately to the placenta to get proper exchange of nutrients. And then we also want nutrients, oxygen and nutrients being transferred from the placental vessels back into the fetal circulation for proper growth. Other than assessing the velocity of blood flow within the umbilical arteries, we also look at the waveform, how it appears, the pattern of the waveform. So we analyze the shape of the blood flow waveform, noting the presence of and strength of the diastolic component. Remember, I mentioned the diastolic component. We go back to our hemodynamics. The peak systolic point is a pressure wave from the fetal heart pump. And then the diastolic component is your reflection from the distal bed, okay? So the diastolic component tells us how blood is going through these umbilical arteries and entering the distal bed, which distal bed is the placental unit. And remember, while we are doing umbilical artery Doppler, we are indirectly assessing the functioning of the placenta. So the strength of the diastolic component, a normal umbilical artery waveform has a low resistance waveform, meaning we have increase in diastolic flow. Increase in diastolic flow at the end of the heart's relaxation phase. There's a lot of blood going through the vessels and into the placenta, going through the arteries and into the placenta. And that is what we want. So the strength lies on it having an increase in diastolic flow. And if the end diastolic flow is reduced, that means we have high resistance in the distal bed. So what it indicates? So normal flow, a healthy umbilical artery Doppler shows a consistent diastolic flow component indicating sufficient blood flow from the placenta to the fetus. From the fetus to the placenta, it's giving you an indirect assessment of the placenta. So if the vessels within the placenta are well dilated, receiving blood properly for proper exchange, so are the ones that are giving back nutrients and oxygen back to the fetus. So because we have the vessels on the maternal side, and then we have the vessels on the fetal side. So the vessels on the fetal side depend on the vessels on the maternal side to be well dilated, to be functioning fully, to do proper exchange between both sides. So our normal umbilical waveform has an increased diastolic flow above the baseline and consistent and continuous. These are some of the normal appearances of umbilical artery Doppler waveforms. First trimester, we have a high resistance waveform. Why is it high resistance waveform? We are not seeing the end diastolic portion. End diastolic portion is just this point at the end of the heart's relaxation before the next systole. Okay? So this connection from one waveform to another, this is our end diastole. And then we have early diastole from here, and then it comes going down, reducing until the end of the diastole, and then we pick up on systole again. So if you look at this waveform, there is no end diastole. Okay? So if there is no end diastole, that means we have increased resistance, high resistance. High resistance where? Remember I said the diastolic component of our umbilical artery waveform is a reflection of the distal bed. The distal bed in this case being our placental bed. So why do we have high resistance in the first trimester? In first trimester, the placenta is just developing. So the vessels are narrowed, everything is just, developing, and the fetus is also just developing. We don't really need a lot of blood for this fetus at this gestational age. The vessels are also tiny, they're just starting to remodel, And now ideally towards, as the pregnancy continues, normally they should be able to dilate, widen, become bigger, and reduce the resistance within them. So this is normal in first trimester. High resistance is very, very normal. Do not see this and say you have placental insufficiency. No, the placenta, the vessels within the placenta are still tiny, they're narrow, it's in the process of remodeling, in the process of formation. So yes, it will be normal to find high resistance. And second trimester, the resistance is also slightly higher. So the absence of one of the components of the diastolic component, they go in order. So this one, which has the end diastole, you can see that the end diastole is present compared to this one that has no end diastole. So this one has a higher resistance than this one. This one has a higher resistance than this one, because you can see the end diastole is very close to the baseline. When the end diastole is high, when the end diastole is reduced close to the baseline, that's what I mean by reduced close to the baseline. That means end diastolic flow within that vessel to its distal bed is finding a bit of resistance. So you'll find this one has a higher resistance than this one because this component is missing, while this one is reduced but present. So this also is normal in second trimester, around early second trimester, 20 weeks, 24 weeks. You may find it slightly high, not as increased as this one. So however, you correlate with your uterine artery Doppler. What is it saying? Do we have early diastolic notching on the uterine artery? Is it in the early second trimester? I have a high resistance. Fine, it's not absent. There is a difference between, they're both high resistance, but one is more severe than the other. Then also you correlate with other parameters such as PI, the RI, and the SD ratio as per gestational age. We shall give you those charts and then you correlate. People have done research and they have the normal values. So with the PI, RI, anything above the 95th percentile for that particular gestational age is considered abnormal. But in most charts, they'll give you something coming from 24 weeks, like we had said, and onwards. So this is a normal late second and third trimester umbilical waveform. Above the baseline, low resistance waveform with increased in diastolic flow, very far from the baseline, which means during my diastolic phase, I'm having adequate flow coming in through the umbilical arteries, going into the placenta without any resistance, properly getting exchange, and also the vessels on the maternal side are not showing any resistance in terms of giving the fetus nutrients that are taken back to the fetal saturation adequately. So abdominal flow, like we've mentioned, high resistance. You will either have high resistance, which means reduction in end diastolic flow. So this will be noted by increasing RI values, PI values, SD ratio. All these values here are giving you a reading on the resistance within the distal bed. Then we have absent end diastolic flow. This is when the RI is equal to 1, where you're not seeing a component of the end diastolic. And then we also have reversal of end diastolic flow. This is a serious sign of a severely compromised placenta and requires urgent attention to prevent fetal harm or fetal death. So still, these are the waveforms. Here we have high resistance, reduced end diastolic flow. Reduced end, my end diastolic point is right there near the baseline, that is reduced, okay? When it's reduced, that is high resistance. What does it mean to be high resistance? High resistance, remember, the diastolic component of this waveform is giving us a reflection of the distal bed. The distal bed in this case being the placenta and the vessels within the placenta. So, for example, during placental insufficiency, let's say the mother has gotten some kind of infection, those viruses that damage the placenta formation, that cause inflammation to the placenta. You've heard of early placental maturation, calcifications, early placental calcifications. All those changes, depending on the mother's condition or what's happening to the mother at that particular point, cause changes in the remodeling of these spiral arteries that supply the placental tissue, where they are going to be useful in exchange of materials. So these vessels will be narrowed, will be damaged, and when they are damaged, there'll be a lot of resistance. Take an example, you have a small door, but then you have a lot of people trying to go through. You'll have just a few people going in, a few people coming out. And then if this door is completely narrowed off later in advanced stages, you will have people trying to push to the door, hit a dead end, and then fall back. That is when you'll have the reversal. So the reversal is the more advanced stage of an abnormal umbilical artery Doppler. We start from high resistance, then the end diastolic component disappears, and then before you know it, we have a reversal of blood flow. Thank you very much for listening. These are charts that we shall share for RI, PI, and SD ratio. You can look through them, compare, and let them guide you. Thank you very much. The rest of your questions, we shall attend to them as we go through the entire discussion. Thank you.
Thank you very much, Naomi, and thank you, IT, for bringing to us a very clear audio. Yes, Naomi did make some corrections. I don't know, Naomi, if you are with us, but you've corrected them in the chat. But she was saying that your Doppler line should be parallel to the vessel. Of course, during the presentation, there's a slip of that tongue where she was saying perpendicular. But remember, when we are perpendicular, we won't have a Doppler shift. So that's the correction she made. The Doppler line should be parallel to the vessel. But of course, when we were hearing from the physics by Mr. Lukenge, he was saying, as long as you are 0 to 30 degrees, you are good. And then, of course, the second trimester normal waveform was described as a sawtooth appearance. And yes, it's also important to note that where we are having the normal waveforms, the first waveforms were showing two vessels, the umbilical artery and the vein. Let's not take note of that when you get the recording. Up you have the artery, the umbilical artery, and then below you have the vein. Yes, so we are continuing. Next, we are going to be looking at the middle cerebral artery. That will be a presentation by Migisa Amina. Yes, time to get another bag of popcorn and enjoy the presentation by Amina. Over to you.
Yes, thank you, Mr. Manja. As already said, my name is Amina Migisa, and I'm going to be talking about the middle cerebral artery in obstetrics. Can you see my screen?
Yes, please.
As already said, my name is Amina Migisa, and I'm going to be talking about the so middle cerebral. Most of the stuff has been discussed by colleagues, so they've paved way. I'm sure my part will be a bit easier. What is the middle cerebral artery? My name is Amina Migisa, and I'm going to be talking about the so middle cerebral. Most of the stuff has been. So as we can see in the image here, let me just get here. This image here, the middle cerebral artery is a branch of the internal carotid artery, and it comes off the terminal end of the internal carotid artery as it joins the sac of Willis at the base of the skull. So we have our internal carotid artery here. As it's joining the sac of Willis, it becomes the what? It gives off the middle cerebral artery, as we can see here. And so this already tells us that when you're doing the middle cerebral artery in obstetrics, you have to point to the base of the skull. So it's one of the largest vessels that supplies oxygen to the brain, and we use it in obstetrics to assess for fetal brain oxygenation in order to detect any responses to reduced oxygen levels in the fetus. And this is because the flow patterns, they directly reflect the distribution of blood flow. For example, in times of stress or in times of fetal compromise, the flow patterns will be directly reflected in the blood flow. So like Mr. Lukeng already told us, this other image is just showing us how the middle cerebral artery looks like sonographically. Mr. Lukeng already told us that under normal circumstances, the fetus is not using the brain, so we don't need a lot of what? We don't need a lot of oxygen in there. So the vessels are small and the resistance is very high. So normally for normal MCA spectral waveforms, they are high resistance. They show a high resistance pattern. And then the moment your high resistance becomes low resistance, or that is like they've explained in the waveforms in the previous presentations, when your diastole starts increasing and going higher above the baseline, then you know there is a problem. That means the fetus is now trying to compensate or is trying to shunt more blood into the brain because of low oxygen levels. So normally what happens in fetal hypoxia, the fetus will reduce the blood flow to the non-vital organs such as the kidneys, the gut, the limbs, and then it will redirect the blood to the vital organs such as the heart, where you're going to have the vessels in the brain dilating to reduce on the resistance and allowing more blood. That is how your waveform becomes low resistance. And this is an adaptive response to protect the brain, but it signifies fetal compromise. So when you see your waveform becoming reduced, so your diastole increasing and more blood being shunted to the brain, you might go ahead to assess the vascular flow, because yes, you've seen redistribution. So what? So you may go ahead and assess the vascular flow, like our colleague Gamos is going to show us in the next presentation. You can assess the ductus venosus, and normally, if the flow in the veins is still normal, then that means that compensation mechanism is still working. But the moment your veins also start showing changes, like the A wave getting closer to the baseline, like we are going to see in the next presentation, then that means now also that compensatory mechanism is failing. So that's when some interventions may come in. Maybe they may deliver a baby, but normally they want to keep this baby as much as possible with the mother inside the womb. So then another thing we see in the MCA is increased PSV, and this is normally observed in fetal anemia. So we have the normal, which is low resistance. We have the normal flow patterns, which is high resistance. Then we have the abnormal that occurs in brain sparing. Then we also have the increased PSV. We've seen that the PSV is the highest point, like in this case here. So normally this is what occurs in anemia. You're going to have the red blood cells in the fetus reducing, the number of red blood cells will reduce. Then the blood viscosity will also reduce. So in return, you're going to have increased venous return and also increased cardiac output. So as this heart is trying to pump harder to compensate for the less oxygen, the PSV is going to rise. That's why in fetal anemia, the PSVs are increased. And normally we have charts for these. There are specific charts for MCA PSVs. So if you see increased PSVs, you can correlate with the chart according to the dictation at hand. These images are still showing us the middle cerebral artery and then the other parts of the sac of Willis. So why do we do the MCA Doppler? Usually to monitor fetal growth restricted fetuses, especially when you do the umbilical Doppler and it shows you increased impedances. So you want to know what's happening in the brain. Is this still getting good oxygen, or is there already a mechanism in place? So that's how you monitor the fetal growth restricted fetuses. Then also we do it to assess for fetal anemia. Like I've explained above, you're going to have increased cardiac output. So you're going to have your systole rising higher. Then also it is done to help in timing of delivery, basically depending on how compromised the fetus is. And how do we do the MCA? Usually, for those that are not very familiar, it is good to always start on the BPD cut, because we are very familiar with this. Everyone does the biparietal diameter every day. So you want to get that cut. Then we already say that the sac of Willis is at the base of the brain. So you want to just go below you get a BPD cut or section. Then just below that cut, as you're moving to the base of the brain, of course, you'll have looked at the position of the fetus, if it is valid.
Sorry, Amina,
yes, please.
I would request that you give us maybe the landmarks for the BP cut. How do I know that now I'm at the BPD cut, the intraventricular?
So that's how you monitor the fetal growth. If someone the cut is here, we have the cavum septum pellucidum, we have this thalami, we have the falx. You want to make sure your sides are all symmetrical and your head is round properly. Usually preferred oval. Then just below that, when you go below that, you get the sphenoid wing. It looks like this. I hope you can see the laser thing. So once you get that sphenoid wing, as you're moving to the base of the skull, you're going to place your color map. Just at this sphenoid wing, you place the color map. Of course, after adjusting your settings, you make sure your color gains are put right, your PRF is right. You're going to get the circle of Willis image here, an image like this. And usually your MCA is on the anterior portion. If you look at this BPD, this is the front, and then this is the back, the occipital end. So using this cavum, then you get the wing, then your MCA is going to be this one in front towards the cavum. So once you get your MCA, you have both sides, you have a right and a left side, depending on the fetal position. Usually it's preferred to use the one closer to the probe for a higher Doppler signal. So then you're going to place your pulse gate. So you've got the sphenoid wing, you've put your color, then you place your pulse gate in the proximal portion of the MCA, proximal third portion. This image depicts it better. You place the gate there. I have a more zoomed image, as you can see here, just where it goes off from the circle of Willis. Then you place your gate. You want the angle to be kept as close to 0 as possible. Sometimes it's impossible to get a good cut of the fetal head, so you'll have to angle correct, but if you can get a 0 angle, that is better. So you have to avoid any unnecessary pressure on the fetal head, which this may lead, because it may lead to increase the PSV or decrease the diastole, increase PR. It can change your readings and give you wrong velocimetries because of your wrong technique. And then you want to have at least three and fewer than 10 waveforms. You don't want a lot of crowding. I think Mr. Lukenge talked about this. The reason you don't want too many waveforms is so that you can look at your image for more details. I'll show you on the next image here. So this is just a summary of what I've talked about above. This criteria is by ISWO. The things you consider when doing your MCA, you look at anatomical site, you look at magnification, angle of insonation, image clarity, sweep speed, and velocity scale. Anatomical site with MCA, you have to make sure you're within the MCA, within the circle of Willis. That's where you find your MCA, then you place. It also includes placing your Doppler gate in the right position, like I said, in the proximal third of the MCA. And then also you want to make sure that image is big enough. It fills at least 50% of the screen. So you either magnify it or you decrease the depth so that you can have a bigger image. Still for detail, you don't want to have a very small image, then you start fidgeting for where to put your point, your gate. Then the angle of insonation, we say it as close to 0 as possible. Less than 15 degrees is fine. Of course, depending on the fetal position, it's not always that you get a good fetus that is lying properly. And then image clarity, you want a clear waveform. As you can see here, no artifacts, so that you can have an accurate trace. Sometimes the waveforms are not really clear because of our settings. maybe your angles are not right, maybe your color, maybe they're liaising. So you have to work on all that so that you have a clear waveform for an accurate trace. Sweep speed, we talked about at least 3 and less than 10 waveforms. I put a small image down here. You don't want too many waveforms. Sweep speed is basically the number of waveforms on display at a given point in time. You don't want to have like 20 waveforms. They are so crowded and it is hard to get the detail on this. But when you have something like this, you can appreciate your diastole, you can appreciate your peak systole properly. Then again, the waveform should occupy at least 75% of the pulse Doppler y-axis. So this is the y-axis, and you don't want these waveforms to be very small. Like you see in the bottom image, they are quite tiny. So that the y-axis scale, you want them to be bigger than this. I mean longer. How you change this is using your PRF. If they are too small, you reduce it, then they will rise up. You don't want them to be, you want them to be at least, there's some guidelines that's at least 50%, but you want at least 75%, as long as you can make them at least big enough for proper detail. That is good. So this slide is about appearances, normal and abnormal appearances in the middle cerebral artery. In first trimester, you're going to have very high resistance monophasic waveforms. You literally don't have any diastolic flow. And then in second trimester, second and third, normally they are high resistance. You have little diastolic flow. And then because like we say, the brain is not working, it doesn't need a lot of blood. It just needs something to keep it going. So when there is a problem and the body realizes, the fetus realizes it's not having enough oxygen in its tissues, it's going to try and save the vital organs, among which is the brain, and we also have the heart. So the vessels in the brain dilate. When they dilate, you're going to have more blood coming in. Like they've been saying in the previous presentations, this diastolic bit, it represents the distal end or the point to which the blood is being supplied. So if it's high, that means now what is getting into the brain is a lot of blood. Initially, under normal circumstances, it's little blood. But because there is a problem and the body is trying to compensate for that problem, these vessels dilate and you have more blood being shunted inside. So this is in cases of brain sparing or fetal hypoxia. This is the waveform you will see. Then we also saw the waveform of fetal anemia, where the systole is very high because of high cardiac output. And then we also have when the PI is less than 5th percentile, this waveform will still look like the one in high diastole in brain sparing. So for the high systole and the PI, you're going to have to look at the charts. There are specific charts for different ages. And then we have pitfalls. Sometimes you might get a reversed end diastolic flow in the brain. Usually it's because of the technique. If you press too hard on the head, and then in cases of impending fetal death, you're also likely to get such a waveform. And then in times of cardiac anomalies, you might also get such a waveform. So every time you get this, the first thing you should check for is your technique and make sure it's not because of your technique. Then you can consider other factors. Then we have what we call the cerebral placental ratio. This one is the ratio of middle cerebral artery PI to umbilical artery PI. And it compares blood flow to the fetal brain versus to the rest of the body through the placenta. Usually a normal CPR or cerebroplacental ratio indicates fetus is healthy and the placenta is functioning properly. When you have a low CPR, it indicates that there is a potential problem, because when this fetus is not getting enough oxygen, it's going to redistribute blood to the vital organs, such as the brain. And when these vessels dilate, the PI decreases. So meaning your ratio is also going to reduce. You will find the blood in the umbilical may decrease or it may remain the same because of the redistribution. But the mere fact that the one in the brain reduces, the PI in the brain reduces, and your CPR reduces, is going to indicate a sign of fetal stress. And studies have shown that the CPR has a greater sensitivity than the individual parameters in predicting adverse neonatal outcomes, and is considered abnormal when less than the 5th centile. Of course, also CPR has charts specific to a given gestation age. So once you calculate, you go and check on the charts, because it seems to have a greater sensitivity, as research has shown recently. This is a table giving us PIs in the umbilical, in the MCA, and the cerebroplacental ratio. So like I've been mentioning, PI, we consider PIs below 5th. In the CPR and the MCA, we consider PIs at this point to be abnormal, or the fetus to be really in distress. For example, if I have a fetus of 33 weeks, and then I get a PI, say, of 1.2, at this point, it's less than the 1.4, which is the 5th centile. This is going to imply that this fetus is having a problem, a big problem. So you might need to mention or alert the doctors or the clinicians concerned as per your departmental protocols. Same as here, cerebroplacental ratio. For umbilical artery, like our colleague said, for it you consider the 95th percentile, the impedances when they are too high. For MCA, CPR, we consider when the impedances are too low, because ideally they should be high, and on this side they should be low. So when these ones rise, so basically MCA is the opposite of umbilical. Even the waveform, a normal waveform in the umbilical, the normal waveform in the umbilical is the abnormal one in the MCA, and the normal MCA is exactly the normal one in the umbilical. So they are opposites. This is just an image summarizing a bit about fetal growth restriction, the middle cerebral artery I've been talking about. This is how an abnormal waveform looks like. Naomi talked about absent end-diastole. Chris has talked about notching in the uterine artery. And also, of course, because of those increased cardiac output and the heart overworking, also there are changes that occur within the heart. So what is the take home? I want to emphasize image optimization, because you can easily misinterpret or give wrong results or miss a diagnosis just because of your technique. You may press the head too high, too much, and you say the fetus is at the verge of death when it's because you overpress the head. You might You might not get your PSV right. You might not place your gate correctly and have a wrong angle. Then you get a less PSV, and you give a fetus normal when it is actually anemic and there is need for intervention. So image optimization plays a crucial role in any successful Doppler ultrasound evaluation. And a lack of understanding of optimization is at the heart of inadequate ultrasound evaluations and finding misinterpretations. And of course, the Doppler parameters should be adjusted throughout the ultrasound examination, just like grayscale. You don't scan the liver and you go to the uterus using the same, you change it according to what favors your image or the point of interest at that point in time. So just like you do that in grayscale, even Doppler parameter, you should adjust them throughout the examination. And every time you get abnormal findings, you should ask yourself, is it a true pathological process or is it an artifact which is associated with my technique? And in case you find any loopholes in your technique, go back and see what you can correct. If you correct it and there's a change, well and good. If you assess yourself, critique, and you see that what you did was what you should have done, then you go confidently with whatever result you got. These are my references. That is what I had for you. Thank you.
Thank you very much, Amina. We are left with one presentation by Mr. Nwagawa Amos. But like I said on the panel, we have a vascular scientist, and I don't want to get in trouble with him. So I want to give us a break so we can have a bit of venous return. Please rise to your feet, stretch a bit so the blood can be helped to move from the feet to your heart. We'll be returning at exactly 2 minutes past 7. Enjoy the break. Yes. See you at 2 minutes past 7.
That's 6.
It is now, sorry, my watch is, it's 6 minutes past 6. So at 12 past 6, that's when we shall be returning. Thanks for the correction, Amina. But let's stretch a bit so our blood can move from the feet. We don't want you to get DVT by sitting a lot.
So
see you at 12 minutes past 6.
So what are we getting when we return?
When we return, we shall be having Mr. Nwagawa Amos tell us about the Ductus venosus. That will be our last presentation before we open up the floor for questions. We already have some questions in the chat. That's what we'll be starting with. Yes, please.
And also ophthalmic artery Doppler, I think.
Oh, yes. Yes, thanks for that. So Mr. Amos will be talking about the ductus venosus and the ophthalmic artery. Enjoy the break. I've taken 1 minute from you, so I'll give it to you. So at 13 minutes past 6, that's when we shall be returning. Let's have a 5 minutes break. Let's replenish the bag of popcorn. Let's replenish the cup of coffee. See you in 5 minutes.
break and nalambye nsoke naye nga nina obuyimba era wali eri nzija
twatandika babiri ne mukwano gwange nga yampa amaanyi kwe kutuuka eno. Twatandika babiri tuti ne mukwano gwange nga yampa amagezi munange kwe kutuuka eno. Naye nawulidde wanyize, omwoyo wanyize, bw'ate ogenda tusaba tondekawaawo. Nawulidde wanyize, omwoyo wanyize, bw'ate ogenda tusaba tondekawaawo. Munange munafu wasembayo wali wanyambala nga tebalaba bunafu bwange. Bampeta w'amaanyi gyempita, bampeta w'amaanyi gyensula, bampeta w'amaanyi lwa mwoyo naye tebamanyi. Ndikawukabuuka buli ayagala yakuba, era amaanyi gennina mba nekwese mu ggwe. Jjukira bwe tuvudde ewala, jjukira bwe wanyambaza ekisa, jjukira bwe wanyanjula mbanene mwoyo tonta, 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 ensajja kunjusayusa ogenda taata.
Right. Thank you, Mr. Ndaula. Be talking to us about the ductus venosus and the ophthalmic artery. Yes. What's their importance in obstetrics and how do we assess them using Doppler? Mr. Nwagaba.
Thank you very much, Mr. Manja. I initially had technical problem. Volume, I'm not sure now if this is much better. Can you hear me now?
Mr. Nwagaba. We can hear you very well.
Thank you so much. So in our last segment of this talk, we are going to talk about ductus venosus and ophthalmic Doppler sonography. I usually like to start with the quote. And will you please, Mr. Mwanja, confirm that you can see my slides?
I'm not seeing your screen.
Oh, is it? Okay, let me unshare. Could Megisa please stop and sharing the screen? Megisa, maybe is that the problem? I will try to share.
Lisa, please stop sharing so Amos can share his screen.
Can you see my slides now?
Not yet.
Yes.
But I'm getting a notification that you are sharing.
Yes, we can see.
Mr. Gerald, you can see Amos's slides.
Yes.
All right, thank you very much. I usually want to start with a quote. This is a quote from Professor Carroll. And he says that a person's true potential is unknown, and it is impossible to foresee what can be accomplished with years of passion, toil, and training. And the message here is that sometimes the work we see, the marveling work that we see by some people who have at it, is usually a result of many years of practice and commitment. And if you trust the process, you can be very sure that obstetric Doppler, which seems to be a skill that is not easy to come by, can be perfected as the learning curve improves. And so our talk this evening is going to be on ductus venosus and
Sir, your voice is too low.
So our talk on this last segment is going to be on ductus venosus and ophthalmic artery sonography. Is that better, sir?
You are still in low voice.
I'm able to get Mr. Nwagaba's voice very well. I'll volume on this.
Okay, all right. I will try to speak maybe louder so that they can.
That's much better.
All right, thank you. So we are going to look at the technique and clinical application. And I will start with the burden of disease. And according to Richard Busayo Olatuji and his colleagues, who conducted a study in Nigeria, and in their study they indicated that the prevalence of preeclampsia ranges from 5 to 10% worldwide, and it is a major cause of maternal mortality and morbidity globally. It is more prevalent in blacks, and this means that if a woman is a black, her pregnancy is likely to be complicated with preeclampsia compared to other races. In Uganda, preeclampsia is the second leading cause of maternal mortality at 15%, and that is after postpartum hemorrhage at 45%, and this is according to Ministry of Health Maternal and Prenatal Deaths Surveillance Response Report 2020 to 2021. And that is for the high-risk pregnancies. And there is also emerging research from Fetal Medicine Foundation that suggests that regardless of the risk profile, we should offer preeclampsia screening to all women at 12, 20, and 36 weeks gestation. And Ductus venosus is a powerful marker in fetal compromise and high-risk pregnancies for risk stratification and for guiding management, especially when it comes to making a decision on when to deliver. Remember, we neither want to deliver too early when you risk disposing the baby to other complications, nor too late when adverse outcomes have already set in. Now, in the first trimester at the 11 to 13 weeks, at 6 days, we use Ductus venosus to assess the risk of chromosomal abnormalities and major cardiac defects. And of course, you will know that we not use this assessment in isolation. We combine it with the biochemistry of the mother, the maternal biochemistry, the mean arterial pressure, and other markers for identifying risks. In the second and third trimester, we use Ductus venosus to assess for FGR, as my colleagues have already mentioned, and for staging, especially for the timing of them. We also use it in evaluation of cardiac function and anomalies, and of course, if in the first trimester you did the Ductus venosus and it was normal, there are sometimes can be other anomalies which can show up later, and we use the Ductus venosus to evaluate the cardiac function. We also use it in fetal anemia and fetal hydrops. And this is just a recap of what we saw earlier. We earlier talked about the shunts, and we have already gone through the fetal circulation, where we have oxygenated blood from the placenta flowing towards the fetus through the umbilical vein. And we know that the fetal liver is not functional like in the adult, and there's no reason for a lot of oxygenated blood flow towards the fetal liver, and that blood is shunted into the IVC and then to the right side of the heart. And this is a very important shunt, and this is going to be the main focus of our talk. So in the technique, we use two approaches, either the sagittal approach of the abdominal view or the transverse approach. Many people find the sagittal approach easier, but of course, when you keep practicing, you know what suits you, and at some point, either approach should be able to enable you to assess the ductus. So what in the sagittal approach, we usually want to start at the level of the umbilical cord attachment, and of course we know this is the umbilical artery, and our interest is the umbilical vein because we are looking at flow towards the baby, and use colored Doppler, you activate colored Doppler and follow the umbilical vein and identify the narrowest portion of the ductus venosus with the narrowest portion of the umbilical vein, which will usually show as an area of aliasing, and that is the area that we are interested in sampling. And you adjust the gate, you adjust the image for you to be able to obtain a good angle, usually which should be less than 30 degrees. And we usually use a small sample volume of 0.5 to 1 millimeter so that you do not interfere the sample from the neighboring vessels of the neighboring ductus process. So, so that is the sagittal approach. And if you use the
recording in
approach,
progress,
we usually want to start from the level of the AC plane. I'm very sure that we are all familiar with the plane that we use for measuring the the abdominal circumference, and that is the starting point. And you then slide the probe cranially towards the head, identify the umbilical vein as it drains into the IVC, and if you fan towards the right, you should be able to see a little bit of the right atria. And this is the area of liaising, and that is the ductus venosus. That is where we sample. There are many guidelines that have been published that guide on the performance of the ductus venosus, and the ISO also published a paper that can give us guidance on the performance of the ductus venosus. In this slide, I have short videos that show us the technique. On the right top corner, we have
Mr. Nwagaba, sorry for interruption. Mr. Daula, can you please resume recording? Let's continue, Mr. Nwagaba.
So on the top upper corner, we have the image showing us the sagittal approach. If you see here, there is an area of aliasing, and that is the ductus venosus, the area that we are interested in sampling. I saw earlier in the chart that how do you know that the fetus is at rest? And remember, of course, this is a dynamic assessment. You want to sample when the fetus is at rest, what we usually call the fetal quiescence. If you see in this image, the fetus keeps jumping up, and you usually want to be patient enough after identifying the vessel that you are interested in. When you activate the spectral Doppler, you want to be patient and take the sample when the fetus is. On the left, we have the short clip of the transverse approach, and here you identify the umbilical vein, then that area that is liaising, that is the ductus venosus that you are interested in. In the left bottom corner is a sample of the appearance of the ductus waveform, and I am not very sure if you can hear the volume, and that is the sound of the ductus venosus. Somebody said that the normal waveform has a sound similar to the sound of a washing machine. And yes, so that is what we have there. Now, on waveform interpretation, the normal waveform is triphasic, but usually above the baseline, and we usually have the highest peak, which we call the S wave, which represents the ventricular systole when the heart is contracting, and the second highest wave is the D wave, which represents the cardiac diastole, or when heart is relaxing, and the last, the lowest point is the A wave, which represents atrial contraction. So on the left is the normal waveform, continuous forward flow throughout the cardiac cycle. And then on the left, we have, and then on the right here, we have the abnormal waveforms. We have already seen the resistance, and we know this is high resistance, which usually happens in the early stages of fetal compromise, either because of congenital abnormality, cardiac abnormality, or in FDR. This is in the early stage when you have low volume of flow through the airway, and you know it is high resistance because it is close to the baseline. In the intermediate stage, in image C is when the air wave is absent, and you know this is going to be a problem to the fetus. In the late stages, usually we know that the ductus venosus, when there is, for example, FGR, the umbilical vein will become, if it changes in the umbilical vein, if it becomes normal, abnormal, then within 2 weeks, you may have the ductus venosus either becoming absent or reversed in image D. So in image D, because we see some flow below the baseline during the airway, and that is really, really very critical when you have reversed airway, and this means that the fetus is seriously compromised and there is impending fetal death. And this is very critical because we know that if this fetus is not delivered within 48 hours, there is going to be a problem. The fetus could end up with IFP. So they are unique Doppler indices. The reason why I put them here, we have already seen PI, RI, but with ductus venosus, they are unique Doppler indices that we need to be familiar with. And the first index is the period index, which is usually a difference of the velocities during the S wave and A wave over the velocity S wave. And the normal is usually low in the sense that the cardiac pressure, because we looked at the fetal circulation and the flow through the ductus venosus is towards the fetal heart, and if the pressure is high in the fetus's heart, it means that is going to restrict the flow in the ductus venosus. And if the preload index is low, we know that is normal, meaning that the flow is flowing to the fetal heart unimpeded. And if it is high, that means that there is increased cardiac pressure, increased in the sense that it is the blood cannot flow from the umbilical vein to the ductus and to the fetal heart. And if it is the preload index is high, that is very concerning. So the second index is peak velocity index for veins, which is a difference between the systolic, the velocity in the S wave minus the velocity in the D wave over the mean velocity, and the normal is also low. The last one on my list is the pulsatility index for veins, which is a difference between the velocity in S wave minus the velocity in A wave over the mean velocity. And also this should decrease as the pregnancy progresses, because that means that the metabolic demand of the growing fetus is increasing, and it is also demanding more flow towards the heart. And if it is high, that means increased arterial pressure. You need to reevaluate. If it is in the first trimester, for example, you look at the heart and be sure that it is not, you are not dealing with the chromosomal abnormality. So in the second and third trimester, of course, you will have assessed the other arteries, you have assessed umbilical artery, you have assessed middle cerebral artery, and you are able to know whether this is cardiac problem, is it a chromosomal problem, or you are dealing with placental insufficiency. So in this image, these are the parameters, the Doppler indices that we need to obtain in the ductus venosus. And after obtaining the waveform, you, depending on the machine that you are using, it will ask you to indicate where the S wave is, B wave, and then the velocity in the A wave, and the equipment will automatically give you the readings. So whatever you do, you have to match it against established reference values, because what can be normal in the first trimester can really be abnormal in the third and second trimester, and therefore you need a reference table for you to be able to interpret your results. In this image on the left, this was a normal Doppler waveform of the ductus for a 22-year-old prime gravitor at 13 weeks for open for a routine obstetric scan. And much as our reference table starts at 14 weeks, the nearest to 13 weeks, that is what we can use. And if you, for example, see here, the period index of 0.7, if you go to our reference table, it would lie between 50th percentile and the 50th percentile. And the normal ranges range between 50th and 95th percentile. So if you have anything that is within this range, that is normal. The second image, it was for a 20-year-old prime gravitor at 29 and 4 days, and the period index was 0.57. And if we go to 29 weeks, 0.57 lies between the 50th percentile and the 95th percentile. And therefore, both these waveforms were for normal pregnancies, and there were no any concerning features. So in this image, I have two images, and I would, if it is okay, if our participants can tell us which of these waveforms is abnormal, and probably tell us why they think so. Why?
There's a question from the panelists. Mr. Amos, are we answering that now?
Yes. Do you want us to listen to maybe give it 5 minutes and hear from what people are saying?
Yes, because it could have a bearing on what you are giving. Manje is saying A is abnormal, so means B is normal.
Would you like to tell us why?
Okay, Mr. Mwanje, please unmute and try to give some explanations for your answer. Korinji Musa is also making the same. Yes, Mwanje.
Thank you very much. This is Mwanje Sean. A is abnormal because I'm seeing reverse A wave, whereas B is normal because I see the A wave is above the baseline.
Thank you very much. We have any person who thinks that the reverse is true?
From the comments I'm reading, it looks like everyone agrees with Mr. Mwanje.
All right.
I've not seen any answer to the contrary.
Yeah, thank you very much. And I thank you, the colleague. Indeed, the A is abnormal because we see the A wave below the baseline, and this is very concerning. And if you are assessing the ductus venosus and you notice that the A wave is reversed, if it is in the first trimester, we need to probably do a comprehensive fetal assessment of the heart and be able that you do not have cardiac abnormality or do karyotyping. If you do the assessment of the heart and it is normal, then that means that you need to do the chromosomal assessment, the karyotyping, to be able to know if this is congenital. And if it is in the third trimester, then so that this baby is delivered early enough before death occurs. So there are some limitations to performance of the of the ductus venosus, and one is that it requires high operator expertise. But of course, as we say, if you keep practicing, learning curve gets better. And remember that no person gets it right at the first go, and you need to keep practicing and practicing for you to be able to perfectly act. It is also influenced by fetal movements, as you saw in our video, that when the fetus is moving, hyperactive, that may affect the quality of the wave. And sometimes the maternal habitus may not favor you to obtain the right image and the angle as well. And sometimes you need to ask the mother to probably change on either the right or the left, so that you are able to pick the right vessel and get the right angle. As of course, angle dependent, and that's why we emphasize that it should be less than 30, and we know that the velocities are dependent, angle dependent, as we saw in the physics. And of course, it is interpreted alongside other Doppler indices. If you did ductus venosus in isolation, it might not really make sense of the information they are obtained, and you need to also make reference to other Doppler indices. So that's it for the ductus venosus. And of course, if there are any questions, I think we will have the opportunity to have a discussion at the tail end of the presentation. We now jump into the ophthalmic artery Doppler, and we know ophthalmic artery Doppler is important because we know it is a branch of the internal carotid artery, and we know that changes happen during pregnancy, and of course we will now know that for the ductus venosus, that is in the fetus, and then for the ophthalmic artery, this is now in the pregnant woman. And we know, because this is a branch of the internal carotid, if we study the flow in the ophthalmic artery, then we will have gained understanding of what is happening in the cerebral saturation. And ophthalmic artery is a very important study because we know that the other approaches of assessing the cerebral perfusion, for example, we would have to do MRI, which is very expensive, or CT scan, which is contraindicated in pregnancy, and access to the ophthalmic artery using sonography becomes a very important approach of assessing the cerebral perfusion. It is very easy to perform, that it can be performed at the bedside as point of care assessment, and in pregnancy we use it to assess cerebral hemodynamics, especially in hypertensive disorders such as preeclampsia. And ophthalmic artery, after it comes off the carotid, many branches, gives off the central retinal artery. Let me pick my pointer here. So this is the central retinal artery. This is posterior ciliary artery, and it also gives off the lacrimal artery. And in terms of anatomy, you see it. This is the optic nerve, and after coming off the internal carotid artery, it crosses medially and then crosses to the lateral side, where it gives off even more branches that go and perfuse the organ. So the technique for ophthalmic artery is such that the patient lies supine with the closed eye, and we use a high frequency linear probe, which should be in the range of 7 to 10 megahertz, and the probe is held in such a way in the horizontal, and the notch points to the right side of the patient. Some people think the right eye is easier to perform. There has been a correlation that the Doppler indices that we obtain from the left eye correlates very well with the contralateral side, and sometimes even when you sample one eye, that is good enough. So we apply a significant quantity of gel because we usually want to avoid exerting a lot of pressure. A lot of pressure, just like in middle cerebral artery, can atrogenically increase the intraocular pressure. The same technique like when we are assessing the middle cerebral artery, where you want to avoid exerting pressure because that increases the pressure within, not because of the change in the hemodynamics, but because of the technique of applying a lot of pressure. And we use color Doppler to identify the ophthalmic artery. Usually you will see the ophthalmic artery crossing either on the medial or lateral side of the optic nerve. In this image, you see some bit of hypoechogenicity, and that is because of the optic nerve. And we want to sample close to the origin of the ophthalmic artery from the internal carotid. Reason being that if you sample too high, remember we have seen that after it comes off the internal carotid, it gives off a number of branches, and if you sample too high, you will have two things: lower velocities, and also you can easily sample not the ophthalmic artery, but any of its branches. You want to keep the angle less than 20 degrees, because we know that the higher the angle, the higher the margin of error. This is, you want to be as accurate as possible. Another thing to always be aware of is the mechanical index and thermal index. If you usually see on the machine, there is usually what is abbreviated as MI and TI, and that is mechanical index and thermal index. And this is very important in examination of the eye, because we know the eye is composed of very delicate structures which are fluid filled, and research shows that if you perform the ophthalmic artery at very high mechanical index and thermal index, you risk the causing complications such as cavitation. And we therefore practice ALALA, where if you can obtain a very good diagnostic image at lower factors of MI and TI, that is okay. How do we change the mechanical index and thermal index? This is usually from the acoustic power, which we know ranges up to 100%. It is usually, the acoustic power is usually expressed in terms of percentage. And if you can have a good diagnostic image at, let's say, 50% of the acoustic power, that is okay. But overall, want to keep the mechanical index at less than 0.3 and thermal index at 1.0. So meaning that going forward, for people who will be very interested in performing the ultrasound of the ophthalmic artery, we need to be aware of this requirement so that we not cause complication. The Doppler indices that we are interested in are PSV and diastolic velocity, IPI, and the P ratio. The rest of these, we are familiar with them. However, I think the peak ratio is a new thing, and we usually get it as a ratio of the peak systolic velocity 2 over peak systolic velocity 2, which we are going to see in our subsequent slides. So the normal waveforms, pregnancy, high resistance. We know they are high resistance when we see this notch. This is what has been described as dicrotic notch. Dicrotic in the sense that the history has two peaks. The first peak, as we know, due to the pressure wave from the heart, should be very sharp one. And because the normal waveform or the normal flow in a pregnant woman should be high resistance. And we saw a number of branches of the ophthalmic artery. That reflection from the branches of the ophthalmic artery will result into this notch. Mr. Pusias described us how the notch comes about because of the reflection. Then that is the notch before the second peak. So if you're calculating the peak ratio, we will get this second peak, the second peak of the systole, which we know as the dicrotic wave, over the first peak, and that will give you the peak ratio. And when the aortic valve closes here, and then the heart is relaxing, that is when we have the diastole. And in the normal state, we should not have high diastolic flow, and if it is low, then we know that is the normal state. So that is the appearance of the normal waveform. The abnormal waveform is when you have breakdown of the autoregulation to the brain, and that is when it breaks down, and then instead of having low resistance, like in this image on the left, you have we have high resistance, but in the abnormal, you have hyperperfusion, and you have raised peak diastolic velocity. So you have, if you compare here, if we look here, let's take this one for diastole. If you go to the scale, you find that the peak diastolic velocity is around 19. However, in the abnormal waveform where you have hyperperfusion, the peak diastolic velocity is around 30. And in the abnormal waveform, we also see because of hyperperfusion, you have raised peak systolic velocities of the second wave. And this means that when you calculate the peak ratio, because this is raised, and in most cases, even PSV1 would be raised, but peak systolic velocity 2 is more raised, and you will have the second peak high over the first peak, and this will be abnormal, this will be low. So in the abnormal waveforms, we usually have reduced peak ratio, which is a feature of hyperperfusion, like happens in preeclampsia. And of course, we know that eventually this causes cerebral edema, and preeclampsia can progress into very severe features of cerebral hyperperfusion. So RI and PI are usually also abnormally low. Usually they should be low, but of course you have to be very careful and see when the PI and RI are abnormally low because of hyperperfusion. So this is a case of a woman who had mild preeclampsia. We know it is mild preeclampsia because we have lost the resistance, we have lost the dicrotic notch. But even when the dicrotic notch is there, you have a dicrotic waveform because of this notching. Before the second peak, you look at the diastolic velocity. If the diastolic velocity is raised and you have a large volume of flow during the diastole, then you know this is abnormal. So the abnormal feature, even when you have preserved the notch before the second peak, you should look at what has happened to the diastole, and if you have a lot of blood flow during the diastole, you still consider it as abnormal feature. So again, we usually make reference to the reference ranges because they act as a guide to interpreting what you have, and at every stage, if you want to know whether the waveform is abnormal, because what can be normal at one point of the gestation can be abnormal at another point, and you can only rely on reference range. So we alone looked at uterine artery, and we said that we also use it for screening, and some people really think that uterine artery may not be as easy as ophthalmic artery. And the good news is that there is very good correlation between uterine artery and ophthalmic artery. And for example, in this woman who was at 26 weeks, the uterine artery showed a persistent notch. When ophthalmic artery was performed, this also showed raised second peak, the peak ratio low. There was also high volume of flow during the diastole, which indicated that there was hyperperfusion and correlated well with the uterine artery. So the take-home messages for ophthalmic artery is that the normal waveform should have two peaks, and it should be dichrotic, a dichrotic waveform. And PI and RI are usually decrease out to the gestation, and peak ratio generally low of roughly less than 0.7. If it increases, that means that we have hyperperfusion. It will be above 0.7, and that is in general terms, and that is efficient of preeclampsia. There is increased peak historic velocities, especially PSV2, as I said, in preeclampsia, which means that we have reduced impedance. Reduced impedance means we have reduction in the flow, and that is the feature of cerebral hyperperfusion. And in conclusion, obstetric Doppler is an invaluable risk assessment tool that is pivotal in the management of pregnancies at risk for complications. And we usually want to do the screening so that you pick out the women whose indices are abnormal, for example, in the first trimester at 11 to 14 weeks, so that you sieve out the women whose indices are abnormal, and you initiate low-dose aspirin, because research has indicated that if you initiate treatment early, before 16 weeks, that's when you can improve outcomes of fetal growth restriction and preeclampsia, which include IUFD and preterm labor. And when we leverage this technique, we can be able to enhance outcomes for both mothers and infants, because we know preeclampsia causes severe disease in the fetus and even the mother long after delivery. Thank you very much. These are the references. I hope we will have a discussion where.
Thank you very much, Mr. Nwagaba. Yes, some members are clapping for you. Thank you very much. Yes, we now move to the questions. First, I want to thank our panelists. Certainly, this doesn't take little effort to prepare. A lot has been put in. We want to thank you. We also want to thank our audience. Thank you for staying with us from 4 to now. We are grateful We want to thank our sponsors, Cairo Medical, yes, for helping us put this together. I'm going to read 3 questions. I'll be reading 3 questions and then our panelists will be answering those. Of course, we've been seeing some answers in the chat, but maybe for emphasis, yes, we can have the answers repeated, and mostly for our audience that is viewing us from YouTube. Mr. Kogi Musa did ask, how do we calculate the mean when one wants to? And then Dr. Dominic says the brain needs more oxygen, but then we are talking of low resistance waveform. We are saying that high resistance is normal, and yet the brain needs more oxygen. How do we marry the two? And then he also asked, between PI, RI, and SD ratio, which parameter is most important to consider? Who do I throw these? Amina, you did present about MCA, so you will be answering Dr. Dominic. And then, yes, our vascular scientist, Mr. Lukenge, question 1 is for you. Then PIRI, I think this is also for you, Mr. Lukenge. PIRI, SD ratio, which one is more important? Mr. Lukenge, how do we calculate the mean if one wants to?
I think everything most of the time is, if you go into preset, everything is completely, you can be calculated by the machine. However, in a situation that you don't have, you need to understand it is a formula that you can use, and that is delta x minus delta t. So if I can just get a page here. So it is a little bit maybe not well, like so what will happen if you've got your this is time, and you have got your vorester here. Okay, so you have your waveform coming there. So what you need is to get the average. So we have the peak systolic there, and you have got time along the way. So it's a little bit complicated because you need to calculate the mean vorester from delta x, that is the change in dispersion from where the wave is starting to that. So you are going to get that average against that time minus the t, the vorester at t. So the best way, I think, would be really to get the preset than really trying to calculate, because in some instances you will find that you are looking for example, for peristaltic index, peristaltic index, then at a certain time you will first have to calculate the resistive index such that you get all the measurements you need, and you substitute to calculate the mean vorester. So I would really say that it would be better if you use the machine calculations. Then I'm not so I don't do obstetric, but what I would think is, to me, if I would be taking the best one would be the peristaltic, because peristaltic takes I'm calculating this waveform and takes the average, also takes the peak, and takes the end diastolic. So I think peristaltic index will be more accurate. I don't know exactly which one is which, because I don't do obstetric, but that I would think because of the parameters which have been taken care of. Yeah, thank you.
Thank you, Mr. Lukenge. Amina, your question here, when you are talking about MCA, you said, yes? Okay. Amina, you did say that when I'm doing MCA, high resistance means normal. Low resistance means abnormal. But then Dr. Dominic was wondering, the brain always needs more oxygen. So why should you say that high resistance is normal? I think you did talk about this during your presentation, but maybe for emphasis, you can give it. Okay, Dr. Dominic said you answered it. Maybe we can just recap it for our members that may not have been on when you presenting.
I think I can also explain that. When the fetus is during the pregnancy, the fetus doesn't need to think. The brain is not function. Therefore, we think the best way of the fetus to be in a normal state is to have restricted vascular beds within the brain, because it is not function and doesn't need more oxygen. Therefore, we get high resistant waveform than when there is a problem. When there is a problem, the fetus goes into survival mode, whereby we shall have increased perfusion to the brain, and that will change high resistant waveform into low resistant waveform. Thank you.
Thank you, Mr. Lukenge. Then we move to the next set of 3 questions. Edson did ask, why don't we sample using the arcuate artery, given that it's a branch of the uterine artery? The second was from Dr. Dominic. Where do we sample in uterine artery and MCA? I think this we are talked about, but we can repeat for emphasis. Mwanje did ask low resistance in uterine artery and high resistance in the umbilical artery during 2nd or 3rd trimester. Please explain.
Yes.
Who do I give?
So
you want to continue, Mr. Lukenge, please?
Yes, I'll take the first question. The first question, when we think about resistance, resistance is in 2 phases. It can be in a series. All right. So if we take the measurement here, we are going to focus on only what is happening here, where it is where it is serving. For example, if you take the accurate artery, so we are going to focus on where that very artery is being served, but we need the corrective resistance. So when we want corrective resistance, we need to take our sample here such that we get the whole picture of what is happening all over there. All right, so that's why we don't take individual small arteries. We take the artery that is serving that particular organ. Thank you.
Much, Mr. Lukenge. Where do we sample in uterine artery, umbilical artery, and MCA? I think this way I talked about. Mr. Maje asked low resistance in uterine artery and high resistance in the umbilical artery during 2nd or 3rd trimester. Please explain. I think this we are talked about. during the presentations, but maybe just to recap, I want to invite Mr. Birenge. So, are you available? Amina, are you there? Again, Mr. Lokeng, I think I can give you the mic to just.
What is the question, Mr. Mwanja? Beg your pardon.
Low resistance in the uterine artery and high resistance in the umbilical artery during second or third trimester. Please explain. The question doesn't look clear because I think if they are normal, then we are supposed to have low resistance all through. Then if they are abnormal, we are supposed to have high resistance all through. But maybe Naomi, you can just make a brief about that. Are you there, Naomi? I think we lost her. Mr. Lukenge, do you want to make a comment?
Ideally, I don't do obstetric.
It's just my network. What was the question?
I was saying my just question wasn't clear because he was saying low resistance in the.
My network. I can't hear. Let someone who is nearby now.
Yeah, if I could repeat my question.
Yes, please, Mwanje.
I'm looking at a scenario because I ever got that one where you have a normal uterine artery, but yet the umbilical artery is abnormal. And I was asking what could be the cause? How can I explain this? Could it be that the placenta issue is not being affected by the uterine artery? Could it be a rupture of placenta? What could cause such a variation? Because I thought if I'm having an abnormal umbilical artery, I'm expecting also the uterine artery to be abnormal. That's what I wanted to be highlighted.
I think from resistant point of view, we can have well supplied myometrium. For example, if maybe you've got any detachment of the or calcified placenta, you may have uterine artery. If there is any, I don't know, but if it is the myometrium is still having good supply, I expect it to get a low resistant waveform. And when you cross over, remember now the uterine is supplying the uterine artery is supplying the myometrium and the placenta, but again we have that boundary between that and myometrium and placenta. So maybe the placenta had issues which did not affect directly the what was happening into myometrium. Thank you.
Mr.
Manjak, can I chip in?
Yes, Mr. Nwagawa, please.
Yeah, thank you very much. So the colleague is asking, you have an abnormal uterine artery and a normal, you have an abnormal umbilical artery in the presence of a normal uterine artery. And if you remember the fetal saturation, we said we have maternal placental saturation versus fetal placental saturation, meaning you have what is going in and what is coming in. So if you have an abnormal uterine artery, that means that probably the problem there is the fetal placental problem and not because of what is coming in through the uterine artery. And in such a scenario, we want to think about the problem with the fetus, not with the mother. So that means we will think about problems like infections of the fetus. I want to think about chromosomal problems and not something that affects what is coming in through the maternal placental circulation. Thank you.
Thank you, Mr. Nwagaba. We move into the last three questions. How do you know the fetus is resting? That was addressed. Why is the RI high at the fetal end compared to the placental end and free loop? Mr. Nwagaba, I want to give you that. But before you answer it, I want to read the third and the last one. Doppler safety in first trimester. Can I use only uterine artery? I think I'm giving you these questions, Mr. Nwagaba. Took two of them. Why is RI high at the fetal end as compared to the placental end and the free loop when you are looking at the umbilical artery? And then lastly, Doppler safety. Yes, we are talking about Doppler. But how safe is it, especially in the first trimester? Mr. Nwagaba.
Thank you very much. The first question, why is resistance high at the fetal end? Is that the question?
Yes, when you are sampling for umbilical artery, why should you use the free loop? Because we're told that there is high resist, the RI is high at the fetal end.
Okay, and yeah, so as you've said, we usually want to sample in the free loop because of those pressure differences. And remember, you've said the flow is from the fetus through the umbilical artery towards the placenta, and you don't want to take anywhere near the insertion ends because of those pressure differences. And before I answer why is there a difference, the only exception is if in the presence of twins. If you have twins, that is when it is encouraged that you sample distal to the insertion, because that is what can be reproduced by any other person who usually wants to maintain consistency even when a different person has sampled. And I will now ask Mr. Mwanja, do you want to tell us why the differences in the resistance at either end?
No, I want to pass that over to another person. Maybe I want to give it to you, Mr. Nwaga, or if Mr. Lukenge has a more precise answer than mine, he could help. But this is my opinion, that perhaps even if there are differences, they won't be so big. That is what I'm thinking.
I think it may be because of the distance. When I was, if I go back to my slides, let me show you something. When we are talking about the flow, we talk about the distance. And the distance, if you see here, there is L, which is the distance of the vessel, all right? So if we have our vessel like that, as long as that, and we have another one as short as that, and this is the distal beds, okay? And this is the distal beds, all right? So the thing is, I beg your pardon. You said where is the highest resistance?
At the fetal end,
At the fetal.
the port insertion.
Yes. So when you look at this distance, all right, and we apply it here, so that means we are going to, when we increase this distance, okay, it is going to reduce the resistance. So if we do here, we sample there, we have all this great distance to assess the reflection from distal bed here. And yet, if we do it here, we sample there, the distance here is going to be too short, all right? So that means here we shall have increased resistance because of the distance, and here we shall have low resistance because of increased the length of the tube. So that is what we consider to be causing in a distance. It is just the length. We drive it from this formula.
Okay, just to supplement.
Yes, please.
Sometimes in placenta insufficiency, because of the vasoconstriction of the vessels within the placenta, they may cause high resistance at both ends. Because the resistance that you're getting at the placenta will also reflect on the resistance from the fetal end. So the instances, especially placenta insufficiency,
so in
when there
case,
is vasoconstriction, clearly the resistances will differ, like
yes. Yes, Naomi, if there is a problem here, we are going to get resistance throughout, but the variation will be less. So his question was, why do we get the distance between the two? And the distance between the two is from hemodynamics. We shall have high resistant there, high resistant, just in case of the problem, but it will not be equal because of distance. Thank you.
Yeah, thank you. Mr. Manja, can I go again? So
yes, please, Mr. Maga.
And this is very interesting because it takes us back to the basics. And we have to ask ourselves, where is that flow coming from? It is coming from the uterine, I mean the iliac arteries, which is coming from the lower limbs. And if you remember the drawings that Mr. Posias showed us, where you have many dividers, you have many, the blood is coming off the many dividers, and that is going to cause resistance. Compared, if you see where the blood is going, it is going to the placenta, which is like a flat, a flat tissue, and there are no many dividers, and that is going to cause less resistance at the placental side compared to the other side, on the fetal side, where the umbilical arteries are coming off from many little branches that reflect that high resistance. So it is all about where are you coming from and where are you going. So at the placental side, it is more, it is like a free, if you do not have placental scarring, it is like free movement, both across and from the other side and to the placenta as well. So that is the reason why we see that change in the resistance, and it is usually lower the placenta side because of where the blood is coming from the fetus.
Thank you. I'll take this last question from our friend Lawrence Kanabi. If the placenta is grade 3, yet we are in second trimester, but the overall velocimetries appear normal, how do we solve the puzzle? Because at times we clash with the obstetricians. My opinion is that ours is to report what we've seen and then hand it over to the obstetricians. But Amos, I want you to give your opinion on this.
Yeah, thank you. So now, if you say third grade placenta, and that is more or less like subjective assessment, which one are you going to to take more? Are you going to say, oh, the placenta is grade 3, you have the lobular classifications, or you are going to rely on a more objective assessment which is saying you that the circulation through the baby is okay? Are you going to be worried about the appearance of the placenta? For me, I think the Doppler assessment is more objective compared to subjective assessment of BMOD. I'm looking at the placenta and you think there's a problem when you do the fetal saturation and it is telling you that the flow through the baby is okay. However, I think it does no harm when you say, let me reevaluate maybe in 2 weeks. And if everything else is okay, that should really not alarm you, because the beauty about Doppler assessment is that it is objective and there is evidence to show. And I think you wouldn't be worried again.
Thank you, Mr. Nwagaba. That marks the end of our questions.
Mr. Nwagaba, also
Yes,
do a
Marie.
biophysical profile, fetal movements, breathing movements, amniotic LIPA, compare with your Doppler, and the best you can do is just monitor.
Thank you. That comes, that marks the end.
Mr. Bernard, and as we've
Yes,
said,
please.
just a short one. Remember, we said you are not doing the Dopplers in isolation. You are doing, maybe if there is need for you to monitor, you are doing the CTG, you are looking at the maternal pressure, diabetes, the patient has no risk factors. And when you compound all these things, you look at them in, as one. You have done this, you've done that, and you look at what you have, together, not just looking at the Doppler in isolation. That should be able to make you make a decision, especially of what you do. Thank you.
Thank you, Mr. Nwagaba. So this will be how we shall close this. The panelists will give their closing remarks, and then my CEO, your network doesn't seem to be nice, so I'll ask Mr. Nwagaba to give a small speech on your behalf. But before that, we have a friend of IFL, Saidat Manga, if she's available. I know she's one of the people that practice this every day. I want to give you 30 seconds to say something, and then I'll move to my panelists to give us their parting words. Saidat, are you there? Maybe she left. So I'll give it to my panelists to give us their parting words. But first, I want to thank you all, our panelists, for the wonderful presentation. This is not only my opinion, but the audience has been clapping for everyone. Thank you very much. I want to thank our IT team for, the network. We are really grateful. So the panelists now, Mr. Lukenge, you did give us the physics and the hemodynamics. A parting word for us.
Thank you so much. Think of the waveform, think which organ you're being supplied, the vessel you are sampling. And the next one is, whenever you think about voreste, always remember angle correction. Thank you so much. And it has been a great time to have you all. Thank you.
Thank you very much. Yes, Crispus, are you there? But I did mention in the chat, thanking you all for attending. And now, may I know your network is not good, but you could just give us a parting word. Naomi, are you there?
Thank you, Monja. Thank
If
you
not,
very much for sharing today's webinar.
yes, please, Naomi.
Thank you, Bernard. Thank you for chairing this meeting. Thank you for chairing the webinar. I'm very proud of Infinite Foundation, and thank you for everyone who attended the webinar. We shall share the recordings, the charts with you. We also have a YouTube channel. We shall share it with you where you can access today's webinar and also the charts that we've promised you and the recording as well. Otherwise, it was a success. Thank you very much. The job had taken me.
Thank you very much, our CEO, Madam Barije Naomi. Amina is gone for prayers, but we want to thank her very much for her presentation, for her very, very wonderful presentation. Mr. Nwagawa, a parting word, of course, that the CEO did speak to us already. So, as a panelist, your parting word.
Yeah, thank you very much. It has been certainly a very humbling experience to be part of this great panel. And the message I want to say to our colleagues out there is that obstetric Doppler is something that comes from research, and whenever you assess features using Doppler, you know what is happening. We should be able to incorporate this standard of care in the work that we do. And as I said, this is all about practice and practice. Certainly, at the beginning, the waveforms may not be very good. You cannot get very good, optimization. And remember, we said there are a number of things. You are looking at the physics. You're looking at a lot of things together, and you cannot get everything on the first go. And you have to keep practicing, because initially, even you will realize you are sampling when the angle is not correct, maybe the gains are not correct. But if you keep practicing, you should be able to, do something that will make all of us proud. And as IFL, I think our goal is to, not just come here and talk about these things, but we want to transform this into the practice that something that we should be able to do. And we ourselves, everyone I see on the team is very available and for us to share. And of course, you have to know that we not know it all, but if we keep practicing and everyone makes their contribution, there is a lot we can achieve. I thank you, colleagues who have attended, and we shall certainly be looking forward to more other engagements. Thank you.
Thank you very much. From the audience, I want to pull out Dr. Dominic. With all due respect, please help me thank our panelists on behalf of the audience. Dr. Dominic, are you there? Looks like he's not there. Yes, Dr. Dominic, we can hear you very well. Yes, please.
Okay. I want to thank all the presenters and Infinite Foundation for the wonderful presentation. So I really learned a lot today. Thank you very much. Thank you very much. I appreciate it.
Thank you
and for
very
all
much.
Yeah.
Thank you very much, Dr. Dominic. We want to thank you, participants, especially those who've kept it with us. Are you still saying something, Dr. Dominic? Sorry?
No, I'm still thanking the audience for being consistent. Like most of the audience, people that are listening to you people. So I want to thank them as well for also contributing and also answering some questions that are related to the presentation. So I want to thank everyone, each and every one of us that attended the online presentation. So
Dr. Dominic, from your accent, I'm sure you are not from Kampala. Am I right to say that you're from Nigeria?
Yes, I'm from Nigeria.
Wow, thank you very much for joining from Nigeria. Greetings to all the people in Lagos and the rest of Nigeria.
Okay, sir.
Yes.
Thank you so much, sir.
Thank you, everyone that's been part of this. Our audience, we thank you very much for the patience. We do apologize for the glitches. Please find it in your kind hearts to forgive us for the things that didn't go right. Our sponsor, Cairo Medical, thank you very much. And the team at IFL, thank you very much. From IFL, we want to wish you a blessed week ahead. Be blessed. Good night.
Yeah.